All right, now we're going to go over the big old boys, the last section, like the main section that we have to go over in terms of this exam that we have. We have others that we need to go over, like for the previous exams, but these are the last one for this exam. So what we're going to do is going over pain management. So my plan is to just read it out loud and talk about what's important. So we're going to jump straight down to this. So I'll just read. I'll get to the part where I don't think... And if I get something important or I need to explain something out, we'll get there. So, acute or chronic pain. Pain is characterized by duration, acute or chronic or pathological condition, like cancer or neuropathic. The two types of pain that you observe in patients are acute, that's transient, and chronic persistent, which includes cancer and non-cancer pain. Acute pain is protective, has identifiable causes, short duration, has limiting tissue damage, and emotional response. It is common after acute injury, disease, or surgery. Acute pain warns people of injury or disease, thus it is protective. Eventually resolves with or without treatment, and an injured area heal after injury. Pain and acute pain are frightened and anxious and expect relief quickly. Self-limiting, therefore a patient knows that an end is in sight. Because acute pain has a predictable ending, healing, and identifiable cause, healthcare team members are usually willing to treat it aggressively. Acute pain seriously threatens a patient's recovery by hampering his or her ability to become active and involved in self-care. Results in prolonged hospitalizations from complications such as physical, emotional exhaustion, immobility, sleep deprivation, and pulmonary complications. Physical and psychological progress is delayed as long as acute pain persists because a patient focuses all energy on pain relief. Efforts aimed at teaching and motivating the patient towards self-care can be hindered until the pain is managed successfully. Complete pain relief is not always achievable, but reducing pain to a tolerable level is a realistic goal. Primary nursing goal is to provide pain relief that allows patients to participate in recovery, prevent complications, and improve functional status. Unrelieved pain can progress to chronic pain. Okay, so I think this is important. So, it's protective, it's identifiable cause, short duration, has limited tissue damage, emotional response. That's important. So it is protective. Why? Because it lets us know the disease. It eventually resolves with or without treatment after it heals. People are frightened and anxious and expect relief quickly. Self-limiting, so there is gonna be an ending, which is good. Then people will treat this aggressively, which is pretty nice. However, threatens the recovery by hampering ability to... That's important. Injury, physical pain. Okay. Chronic or persistent non-cancer pain. IOM estimates that chronic pain affects approximately 100 million American adults, more than the total affected by heart disease, and diabetes. Unlike acute pain is not protective and thus serves no purpose, has a dramatic effect on the person's quality of life. Chronic non-cancer pain is prolonged, varies essentially, usually lasts longer, typically at least 6 months than is expected or predicted, does not have an identifiable cause, and leads to great personal suffering. Some good examples are arthritis, low back pain, headache, fibromyalgia, and peripheral neuropathy. It may result from an initial injury such as a back sprain, or there be an ongoing cause such as illness. Chronic non-cancer pain may be viewed as a disease since it has a distinct pathology that causes changes throughout the nervous system that may worsen over time, significant physiological, psychological, and cognitive effects, and can constitute a serious separate disease entity itself. Chronic non-cancer pain is usually non-threatening. In some cases, an injured area healed long ago, yet the pain is ongoing and does not respond to treatment. So, cause of chronic pain combined with ineffective treatments and unrelenting nature and uncertainty of duration frustrates the patient, frequently leading to psychological depression and even suicide. Chronic pain is a major part of psychological and physical disability, leading to problems such as job loss, inability to perform simple daily activities, sexual dysfunction, social isolation. The goal of treating chronic non-cancer pain is to improve functional status within a multimodality plan. A person with chronic non-cancer pain often experiences pain that may not have the same physiological response as acute pain, subjective reports, and interferes with daily activity. Okay, hang on. That's killing my voice.
1014. A person with chronic non-cancer pain often experiences pain that may not have the same physiological response as acute pain. However, the subjective reports and interference with activities of daily living, ADLS, socialization, and ability to perform work duties is very real. Patients often suffer more with time because of physical and mental exhaustion. Associated symptoms of chronic pain include fatigue, insomnia, anorexia, weight loss, apathy, hopelessness, depression, and anger. Chronic pain creates the uncertainty of how one will feel from day to day. A person with chronic non-cancer pain often does not show obvious symptoms and does not adapt to the pain. Healthcare providers are usually less willing to treat chronic pain with opioids, although there are guidelines that support their use. Joe et al., 2009. In addition, the American Society of Anesthesiologists, 2010, released practice guidelines for chronic pain management, which includes opioid use. Often a person with chronic pain who consults with numerous healthcare providers is labeled a drug seeker, when he or she is actually seeking adequate pain relief. Nurses need to discourage patients from having multiple healthcare providers for treating pain and refer them to specialists. Pain centers offer non-pharmacological and pharmacological strategies for a holistic approach to pain management.
Okay, so chronic pain is not protective and serves no purpose but has a general effect on the person's quality of life. Some examples are going to be arthritis, low back pain, headache, fibromyalgia, peripheral neuropathy, things like that. The goal of treating chronic non-cancer pain is to improve functional status with the multimodality plan. That makes sense. Associated symptoms of chronic pain have some fatigue, anxiety, insomnia, anorexia, weight loss, apathy, hopelessness, depression, anger, stuff like that. I think the big one here is they're less willing to treat chronic pain with opioids. And then often the person with chronic pain who consults numerous healthcare providers is labeled a drug seeker. That one's a poor one, I think, too. Okay.
Chronic episodic pain. Pain that occurs sporadically over an extended period of time is episodic pain. Pain episodes last for hours, days, or weeks. An example of chronic episodic pain is the migraine headache that occurs up to 14 days per month compared to chronic migraine that occurs more than 15 days per month. Katsarova et al., 2012. Cancer pain. Not all patients with cancer experience pain. For those who do, many are able to have their pain managed with relatively simple means. Burcham and Rosenthal, 2016. Some patients with cancer experience acute and/or chronic pain. The pain is normal, nociceptive, resulting from stimulus of an undamaged nerve and/or neuropathic, arising from abnormal or damaged pain nerves. Table 44-2. Cancer pain is usually caused by tumor progression and related pathological processes, invasive procedures, toxicities of chemotherapy, infection, and physical limitations. A patient senses pain at the actual site of the tumor or distant to the site, called referred pain. Always completely assess reports of new pain by a patient with existing pain. Despite the availability and wide use of opioids and updated guidelines from reliable leading professional societies, undertreatment of cancer pain is still frequent. More than 75% of patients with advanced cancer experience pain, yet research shows that approximately one-third of patients still do not receive pain medication proportional to their pain intensity. Greco et al., 2014, Payas and Farrell, 2011. Table 44-2. Classification of pain by inferred pathology. Nociceptive pain. Neuropathic pain. Nociceptive pain, normal stimulation of special peripheral nerve endings called nociceptors, usually responsive to non-opioids and/or opioids. Somatic pain, comes from bone, joint, muscle, skin, or connective tissue, is usually aching or throbbing in quality and well localized. Visceral pain, arises from visceral organs such as the gastrointestinal tract and pancreas, is sometimes subdivided. One tumor involvement of organ capsule that causes aching and fairly well localized pain. 2. Obstruction of hollow viscus, which causes intermittent cramping and poorly localized pain. 2. Neuropathic pain, abnormal processing of sensory input by the peripheral or central nervous system. Treatment usually includes adjuvant analgesics. Centrally generated pain. 1. Deafferentation pain, injury to either the peripheral or central nervous system. Examples: phantom pain indicates injury to the peripheral nervous system. Burning pain below the level of a spinal cord lesion reflects injury to the central nervous system. 2. Sympathetically maintained pain, associated with impaired regulation of the autonomic nervous system. Examples: pain is associated with complex regional pain syndrome, type I, type 2. Peripherally generated pain. 1. Painful polyneuropathies, pain felt along the distribution of many peripheral nerves. Examples: diabetic neuropathy, alcohol nutritional neuropathy, and Guillain-Barré syndrome. 2. Painful mononeuropathies, usually associated with a known peripheral nerve injury. Pain is felt at least partly along the distribution of the damaged nerve. Examples: nerve root compression, nerve entrapment, trigeminal neuralgia.
Okay, so I think these are important. This table is very important. So nociceptive is the stimulation of the nociceptors, but the thing is they're treated, usually responds to opioids. The somatic, that's the bone, joint, muscle, connective tissue. It feels aching or throbbing, well localized. And visceral, that's like the internal organs. So like tumor involvement, stuff like that. The neuropathics is abnormal. And you apparently treat them with adjuvant analgesics. So you got deafferation pain, peripheral central nervous system, sympathetic maintained pain is associated with impaired nervous system, and you have these two as well. So, can I talk about later?
From Paciro C., McCaffrey M., Pain Assessment and Pharmacologic Management, St. Louis, 2011, Mosby. Idiopathic pain. Idiopathic pain is chronic pain in the absence of an identifiable physical or psychological cause or pain perceived as excessive for the extent of an organic pathological condition. An example of idiopathic pain is complex regional pain syndrome, CRPS. Research is needed to better identify the causes of idiopathic pain to identify more effective treatment. Paciro and McCaffrey, 2011. Nursing knowledge base. Nursing knowledge of pain mechanisms and interventions continues to grow through nursing research. This section explores factors that influence the pain experience. Knowledge, attitudes, and beliefs. Attitudes of nurses and other healthcare providers affect pain management. The traditional medical model of illness generates attitudes about pain. This model suggests that physical problems result from 10-19 physical causes. Thus pain is a physical response to organic dysfunction. When there is no obvious source of pain, example the patient with chronic low back pain or neuropathies, healthcare providers sometimes stereotype pain sufferers as mailingers, complainers, or difficult patients. Studies of nurses' attitudes regarding pain management show that a nurse's personal opinion about a patient's report of pain affects pain assessment and titration of opioid doses. It has been shown that nurses' assessment of pain intensity underestimates patients' pain reports, et 2013. A number of nurse and patient variables, including cultural, example gender, age, education, knowledge, and patient diagnosis, may contribute to the differences in pain ratings. The amount of analgesia administered may vary on the basis of whether a patient is grimacing or smiling during the nurse's assessment. Paciro and McCaffrey, 2011. Nurses with more than 6 years of work experience, higher job motivation, and perceived higher levels of pain care skills in themselves often use more patient advocacy skills in providing pain management for patients. Vardio et 2009. Nurses' assumptions about patients in pain seriously limit their ability to offer pain relief. Biases based on culture, education, and experience influence everyone. Too often nurses allow misconceptions about pain, box 44-2, to affect their willingness to intervene. Some nurses avoid acknowledging a patient's pain because of their own fear and denial. They do not believe a patient's report of pain if he or she does not look in pain. A nurse is entitled to personal beliefs, however, he or she must accept a patient's report of pain and act according to professional guidelines, standards, position statements, policies, and procedures, and evidence-based research findings. Paciro and McCaffrey, 2011. Box 44-2. Common biases and misconceptions about pain. The following statements are false. Patients who abuse substances, example use drugs or alcohol, overreact to discomforts. Patients with minor illnesses have less pain than those with severe physical alteration. Administering analgesics regularly leads to drug addiction. The amount of tissue damage in an injury accurately indicates pain intensity. Healthcare personnel are the best authorities on the nature of a patient's pain. Psychogenic pain is not real. Chronic pain is psychological. Patients who are hospitalized experience pain. Patients who cannot speak do not feel pain.
Okay, so this table is obviously important. Common biases and misconceptions about pain. So all these statements here are false. So it says patients who abuse substances overact discomforts. It's not true necessarily. Patients with minor illnesses have less pain than those with severe physical alteration. No. Administering analgesics regularly leads to addiction. Not always. The amount of tissue damage in an injury accurately indicates pain intensity. Not true. Care personnel are the best authorities on the nature of patient pain. No, the patient is. Psychogenic pain is not real. Not true. Chronic pain is psychological. Not true. Patients who are hospitalized experience pain. Not always. Patients who cannot speak do not feel pain. That's not true at all.
To help a patient gain pain relief, it is important to view the experience through the patient's eyes. Acknowledging a personal prejudice or misconception helps to address patient problems more professionally. When one becomes an active, knowledgeable observer of a patient in pain, it is possible to more objectively analyze the pain experience. The patient makes the diagnosis that pain is present, and the nurse provides interventions that ultimately offer relief. Factors influencing pain. Pain is a complex process, involving physiological, social, spiritual, psychological, and cultural influences. Thus each individual's pain experience is different. Consider all factors that affect a patient in pain to ensure a holistic approach to the assessment and care of the patient. Physiological factors. Age. Age influences the pain experience. It is important to consider how a painful event affects a patient developmentally. For example, pain may prevent an adolescent from engaging socially with friends. A middle-aged adult may be unable to continue work in cases when it is severe. It is particularly important to recognize how developmental differences affect how infants and older adults react to pain. Young children have trouble understanding pain, its meaning, and the procedures that cause it. If they have not developed full vocabularies, they have difficulty verbally describing and expressing pain to parents or caregivers. Toddlers and preschoolers are unable to recall explanations about pain or associated with experiences that may not be related to the painful condition. With these developmental considerations in mind, it is necessary to adapt approaches for assessing a child's pain, example what to ask, including parents, the behaviors to observe, and how to prepare a child for a painful medical procedure. Pain is not an inevitable part of aging. Likewise, pain perception does not decrease with age. However, older adults have a greater likelihood of developing pathological conditions, which are accompanied by pain. In addition, age-related changes and increased frailty may lead to a less predictable response to analgesics, increased sensitivity to medications, and potential harmful drug effects. Van Ojik et al., 2012. The person in pain, his or her family, and healthcare providers frequently take their chronic medical conditions for granted and underestimate the pain. Serious impairment of functional status often accompanies pain in older patients. It potentially reduces mobility, ADLS, social activities, and activity tolerance. The presence of pain in an older adult requires aggressive assessment, diagnosis, and management. Box 44-3. Box 44-3. Focus on older adults. Factors influencing pain in older adults. With aging, muscle mass decreases, body fat increases, and percentage of body water decreases. This increases the concentration of water-soluble drugs such as morphine given in normal doses. The volume of distribution for fat-soluble drugs such as fentanyl increases. Burcham and Rosenthal, 2016, Tracy and Morrison, 2013. Older adults frequently eat poorly, resulting in low serum albumin levels. Many drugs are highly protein-bound. In the presence of low serum albumin, more free drug, active form, is available, thus increasing the risk for side and/or toxic effects. Burcham and Rosenthal, 2016, Tracy and Morrison, 2013. A decline of liver and renal function naturally occurs with aging. This results in reduced metabolism and excretion of drugs. Thus older adults often experience a greater peak effect and longer duration of analgesics. Arnstein, 2010. Age-related changes in the skin such as thinning and loss of elasticity affect the absorption rate of topical analgesics.
Okay, so I think this is important too. Factors influence pain in older adults. Bro. So we know when they age, they get more fatty, they lose their muscle, and body water decreases. So that means you give 100 grams of something in 100 liters, it'll be like 1 for 1. 1 liter to 1 gram. But when that decreases to like 50, it's now 1 liter has 2 grams. So it has more. So it has an increased concentration of water soluble, and the volume of distribution for fat soluble drugs as fentanyl increases, which is kind of crazy because you have less water and you have more fat. Older adults, they don't eat as healthy, not all of them, so they have low serum albumin levels, and if they have low, they can't bind to protein, so then there's more drug available, increasing risk of side and adverse effects, and then obviously the liver and renal function normally declines with aging, so metabolism and excretion of drugs is reduced, so they might have a greater peak effect and longer duration analgesics, and then skin, such as thinning and loss of elasticity, affect the absorption of topical analgesics, stuff like that.
The ability of older patients to interpret pain is sometimes complicated. They often suffer from multiple diseases with symptoms that affect similar parts of the body. The nurse must make detailed assessments when the source of pain is not clear. Different diseases sometimes cause similar symptoms. For example, chest pain does not always indicate a heart attack, it also is a symptom of arthritis of the spine or an abdominal disorder. When older adults experience cognitive impairment and confusion, they have difficulty recalling pain experiences and providing detailed explanations of their pain. Passero and McCaffrey, 2011. It is necessary to address misconceptions about pain 1020 management in the very young and in older adults before intervening for a patient. Tables 44-3 and 44-4. Table 44-3. Pain in infants. Misconception. Correction. Infants cannot feel pain. Infants have the anatomical and functional requirements for pain processing by mid to late gestation. Infants are less sensitive to pain than older children and adults. Term neonates have the same sensitivity to pain as older infants and children. Preterm neonates have a greater sensitivity to pain than term neonates or older children. Infants cannot express pain. Although infants cannot verbalize pain, they respond with behavioral cues and physiological indicators that are observable. Infants must learn about pain from previous painful experiences. Pain requires no prior experience. Infants do not need to learn it from earlier painful experience. It occurs with the first insult. You cannot accurately assess pain in infants. You use behavioral cues, example facial expressions, cry, body movements, and physiological indicators of pain, example changes in vital signs, to reliably and validly assess pain in infants. You cannot safely give analgesics and anesthetics to infants and neonates because of their immature capacity to metabolize and eliminate drugs and their sensitivity to opioid-induced respiratory depression. Infants are very sensitive to drugs. Response to drugs is often intense and prolonged. Absorption is faster than expected. Dosages of drugs excreted by the kidneys need to be reduced. Burcham and Rosenthal, 2016. Prescribers carefully select the medication, dosage, administration route, and time. Nurses monitor frequently for desired and undesired effects. They also follow medication orders to titrate and wean medications to minimize adverse effects. Table 44-4. Misconceptions about pain in older adults. Misconception. Correction. Pain is a natural outcome of growing old. Older adults are at greater risk, as much as twofold, than younger adults for many painful conditions. However, pain is not an inevitable result of aging. Pain perception, or sensitivity, decreases with age. This assumption is unsafe. Although there is evidence that emotional suffering specifically related to pain may be less in older than in younger patients, no scientific basis exists for the claim that a decrease in perception of pain occurs with age or that age dulls sensitivity to pain. If the older patient does not report pain, he or she does not have pain. Older patients commonly underreport pain. Reasons include expecting to have pain with increasing age, not wanting to alarm loved ones, being fearful of losing their independence, not wanting to distract, anger, or bother caregivers, and believing that caregivers know they have pain and are doing all they can to relieve it. The absence of a report of pain does not mean the absence of pain. If an older patient appears to be occupied, asleep, or otherwise distracted from pain, he or she does not have pain. Older patients often believe that it is unacceptable to show pain and have learned to use a variety of ways to cope with it. Example: many patients use distraction successfully for short periods of time. Sleeping is sometimes a coping strategy. Alternately, it indicates exhaustion, not pain relief. Do not make assumptions about the presence or absence of pain solely on the basis of a patient's behavior. The potential side effects of opioids make them too dangerous to use to relieve pain in older adults. Opioids are safe to use in older adults with moderate to severe pain. Arnstein, 2010. Although the opioid-naive older adult is usually more sensitive to opioids, this does not justify withholding their use in pain management. Slow titration prevents potentially dangerous opioid-induced side effects. Regular, frequent monitoring and assessment of a patient's response are necessary. Adjust dose and the interval between doses when you detect side effects. If necessary, administer an opioid antagonist drug to reverse clinically significant respiratory depression. Patients with Alzheimer's disease and other cognitive impairments do not feel pain, and their reports of pain are most likely invalid. No evidence exists that cognitively impaired older adults experience less pain or that their reports of pain are less valid than those of individuals with intact cognitive function. Hare, 2010. Patients with dementia or other deficits of cognition most likely suffer significant unrelieved pain and discomfort. Assessment of pain in these patients is challenging but possible. The best approach is to accept a patient's report of pain and treat it as you would treat it in an individual with intact cognitive function. Older patients report more pain as they age. Even though older patients experience a higher incidence of painful conditions such as arthritis, osteoporosis, peripheral vascular disease, and cancer than younger patients, studies show that they underreport pain. Many older adults grew up valuing the ability to grin and bear it. Passero and McCaffrey, 2011.
Okay, I think these two tables are important, the pain in infants specifically. So people say infants can't feel pain, however they can start start kind of processing it by mid to late gestation. It also says infants are less sensitive to pain than older adults and older children and adults. That's not true. Term neonates have the same sensitivity, where preterm neonates have actually greater sensitivity. It says infants cannot express pain. Infants can't verbalize pain, but they do like the behavioral cues. Infants must learn about pain from previous painful experience. Nope, it's not true. When they get pain the first time, they'll figure it out. They basically know what's up. You cannot accurately assess pain in infants. Maybe not verbally, but you can use behavioral cues and stuff like that. You cannot safely give analgesics and anesthetics to infants and neonates because of their immature capacity to metabolize and eliminate drugs and sensitivity to opioid-induced respiratory depression. It's not true. You just have to adjust the dosage and monitor them. Misconceptions about pain in older adults. Pain is a natural outcome of older growing age. We know that older adults are at greater risk for many painful conditions. However, pain is not a normal aging process. Pain perception or sensitivity decreases with age. There's actually no evidence that says this is true. If the older adult patient does not report pain, he or she does not have pain. It's not true. They may not want to report it because they don't want to lose their independence or stuff, so they might hold back. If an older adult appears distracted, he or she does not have pain. It's not true. If you're distracting yourself, you're kind of getting your mind off it. You're not thinking about it. The potential side effect of opioids make them too dangerous to use to relieve pain in older adults. It's not true. Again, you can adjust and monitor them very closely. Patients with Alzheimer's disease and other cognitive impairments do not feel pain in their reports. Pain are most likely invalid. Not true. We have no real evidence of it. Older adults report more pain as age. It's actually not true. They actually underreport pain.
Fatigue. Fatigue heightens the perception of pain and decreases coping abilities. If it occurs along with sleeplessness, the perception of pain is even greater. Pain is often experienced less after a restful sleep than at the end of a long day. Genes. Research on healthy human subjects suggests that genetic information passed on by parents possibly increases or decreases a person's sensitivity to pain and determines pain threshold or tolerance. Recent advances in the study of genetics and pain have shown that even slight changes in deoxyribonucleic acid, DNA, could partially explain individual differences in pain. Genetic influences have been 1021 shown to play a role in sensitivity, perception, and expression of pain. James, 2013. Neurological function. A patient's neurological function influences the pain experience. Any factor that interrupts or influences normal pain reception or perception, example spinal cord injury, peripheral neuropathy, or neurological disease, affects a patient's awareness of and response to pain. Some pharmacological agents, analgesics, sedatives, and anesthetics, influence pain perception and response because of the manner in which they affect the nervous system. Social factors. Attention. The degree to which a patient focuses attention on pain influences its perception. Increased attention is associated with increased pain, whereas distraction is associated with a diminished pain response. This concept is one that nurses apply in various pain relief interventions such as relaxation, guided imagery, and massage. By focusing patients' attention and concentration on other stimuli, their perception of pain declines. See Chapter 33. Previous experience. Each person learns from painful experiences. Prior experience does not mean that a person accepts pain more easily in the future. Previous frequent episodes of pain without relief or bouts of severe pain cause anxiety or fear. In contrast, if a person repeatedly experiences the same type of pain that was relieved successfully in the past, he or she finds it easier to interpret the pain sensation. As a result, the patient is better prepared to take necessary actions to relieve the pain. When a patient has no experience with a painful condition, the first perception of pain often impairs the ability to cope. For example, after abdominal surgery, patients often experience severe incisional pain for several days. Unless a patient knows that this is a common occurrence following surgery, the onset of pain seems like a serious complication. Rather than participate actively in postoperative breathing exercises, see Chapter 50, the patient lies immobile in bed and breathes shallowly because of fear that something is not right. In the anticipatory phase of the pain experience, you need to prepare a patient with a clear explanation of the type of pain to expect and methods to reduce it. This usually results in a reduced perception of pain. Family and social support. People in pain often depend on family members or close friends for support, assistance, or protection. Although pain still exists, the presence of family or friends can often make the experience less stressful. Conversation with family is a useful distraction. The presence of parents is especially important for children experiencing pain. Spiritual factors. Spirituality is an act of searching for meaning in situations in which one finds oneself. Chapter 36. Spiritual beliefs affect the way patients view or cope with pain. Research studies have demonstrated that spiritual beliefs and preferences for spiritual interventions have been useful in pain management. Desutter et al., 2011, Weinstein et al., 2014. Patients often ask spiritually based questions such as, why has this happened to me? Why am I suffering? Spiritual pain goes beyond what we can see. Why has God done this to me? Is this suffering teaching me something? Other spiritual concerns include loss of independence and becoming a burden to family. Consider making a referral to pastoral care for patients in pain. Recall that pain is an experience that has physical and emotional components. Thus, providing interventions designed to treat both aspects is essential for the best possible pain management. Psychological factors. Anxiety. A person perceives pain differently if it suggests a threat, loss, punishment, or challenge. For example, a woman in labor perceives pain differently than a woman with a history of cancer who is experiencing a new pain and fearing recurrence. In addition, the degree and quality of pain perceived by a patient influences its meaning. The relationship between pain and anxiety is complex. Anxiety often increases the perception of pain, and pain causes feelings of anxiety. It is difficult to separate the two sensations. Critically ill or injured patients who perceive a lack of control over their environment and care have high anxiety levels. This anxiety leads to serious pain management problems. Pharmacological and non-pharmacological approaches to the management of anxiety are appropriate. However, anxiolytic medications are not a substitute for analgesia. Ch44 and McCaffrey, 2011. Coping style. Pain is a lonely experience that often causes patients to feel a loss of control. Coping style influences the ability to deal with it. People with internal loci of control perceive themselves as having control over events in their life and the outcomes such as pain. They ask questions, desire information, and make choices about treatment. In contrast, people with external loci of control perceive that other factors in their life such as nurses are responsible for the outcome of events. These patients follow directions and are more passive in managing their pain. Learn to understand patients' coping resources during painful experiences so you can incorporate these into your plan of care. For example, a patient who does not ask for pain medication but shows behavioral signs of discomfort might require you to be more responsive in offering PRN medications on time. See Chapter 38. Cultural factors. The meaning that a person associates with pain affects the experience of pain and how one adapts to it. This is often closely associated with a person's cultural background, including age, education, race, and familial factors. Cultural beliefs and values affect how individuals cope with pain. They learn what is expected and accepted by their culture, including how to react to pain. Healthcare providers often mistakenly assume that everyone responds to pain in the same way. Different meanings and attitudes are associated with pain across various cultural groups. An understanding of the cultural meaning of pain helps you design culturally sensitive care for people with pain. Ch44 and McCaffrey, 2011. Culture affects pain expression. Some people believe that it is natural to be demonstrative about pain. Others tend to be more introverted. When a person moves to another country, it is important to know to what extent the individual has assimilated into his or her new home. For example, if several generations of a Hispanic patient's family have lived in the United States, the influence of the Spanish culture may be limited, whereas newly immigrated patients still often embrace their cultural norms. As a nurse, explore the impact of cultural differences on a patient's pain experience and make adjustments to the plan of care. Box 44-4. Ask if the patient has had any previous bad experiences with pain management. Work with the patient and family to learn their cultural beliefs, values, and preferences to adequately assess and manage pain. Chapter 9. Find a culturally appropriate assessment tool and communicate use of that tool to other healthcare providers. Box 44-4. Cultural aspects of care. Assessing pain in culturally diverse patients. Pain is a biopsychosocial phenomenon. Culture shapes the experience of pain, including its expression and a patient's behaviors, or coping responses. For example, an individual from a higher socioeconomic group has more resources for managing pain and is more likely to adapt behaviors that will lessen pain. One research study showed that people in the lowest as compared to the highest socioeconomic class were 2 to 3 times more likely to feel disabled through pain. Dorner et al., 2011. Culture also affects a person's choice of lay remedies, help-seeking activities, and receptivity to medical treatment. Some healthcare providers undertreat pain because they do not understand the cultural effects on the perception of pain intensity. Nurses care for patients with pain from a variety of cultural backgrounds, thus you need to develop strategies to assess and manage pain in culturally diverse patients. Implications for patient-centered care. Use culturally appropriate assessment tools such as tools written in the patient's native language to assess pain. Ch44 and McCaffrey, 2011. Assess the patient's health literacy level because this affects your ability to provide appropriate education about pain management and therapies. Recognize variations in subjective responses to pain. Some patients are stoic and less expressive, whereas others are emotive and more likely to verbalize pain. Be sensitive to variations in communication styles. Some cultures believe that nonverbal expression of pain is sufficient to describe the pain experience, whereas others assume that, if pain medication is appropriate, the nurse will bring it, thus asking is inappropriate. Understand that expression of pain is unacceptable within certain cultures. Some patients believe that asking for help indicates a lack of respect, whereas others believe acknowledging pain is a sign of weakness. The meaning of pain varies among cultures. Pain is personal and related to religious beliefs. Some cultures consider suffering a part of life to be endured to enter heaven. Use knowledge of biological variations of pain. Significant differences in drug metabolism, dosing requirements, therapeutic response, and adverse effects occur in cultural groups. A wide range of responses is also possible within this group. Therefore, assess each patient's response to pain medication carefully. Develop a personal awareness of your own values and beliefs that affect your responses to patients' reports of pain. Critical thinking. Successful critical thinking requires a synthesis of knowledge, experience, information gathered from patients, critical thinking attitudes, and intellectual and professional standards. To make clinical judgments, you anticipate the information you need, analyze the data, and make decisions regarding patient care. A patient's condition or situation is always changing. During assessment, consider all critical thinking elements that lead to appropriate nursing diagnoses. 1022. Knowledge of pain physiology and the many factors that influence pain help you manage a patient's pain. Previous experience in caring for patients with pain sharpens your assessment skills and ability to choose effective therapies. Critical thinking attitudes and intellectual standards ensure the aggressive assessment, creative planning, and thorough evaluation needed to obtain an acceptable level of patient pain relief while balancing treatment benefits with treatment-associated risks. Successful pain management does not necessarily mean pain elimination but rather attainment of a mutually agreed-on pain relief goal that allows patients to control their pain instead of the pain controlling them. Nursing process. Apply the nursing process and use a critical thinking approach in your care of patients. The nursing process provides a clinical decision-making approach for you to develop and implement an individualized plan of care. Nurses approach pain management systematically to understand and treat a patient's pain. Successful management of pain depends on establishing a relationship of trust among healthcare providers, patient, and family. Pain management extends beyond relief, encompassing the patient's quality of life and ability to work productively, enjoy recreation, and function normally in the family and society. The American Nurses Association, ANA, 2005, upholds that pain assessment and management is within the scope of every nurse's practice. Thus the ANA offers a certification examination in pain management to staff nurses, http://www.asbmn.org/certification. Several clinical guidelines are available for managing pain in specific disorders. Guidelines are available through the American Pain Society, APS, on the management of pain in the primary care setting, sickle cell pain, cancer pain in adults and children, and pain in osteoarthritis, rheumatoid arthritis, and juvenile chronic arthritis. Sigma Theta Tau International offers guidelines for the older adult on its website, www.geriatricpain.org. In addition, the National Guidelines Clearinghouse, www.guideline.gov, posts a variety of pain management guidelines. Assessment. During the assessment process, thoroughly assess each patient and critically analyze findings to ensure that you make patient-centered clinical decisions required for safe nursing care. A comprehensive assessment of pain aims to gather information about the cause of a person's pain and determine its effect on his or her ability to function. Through the patient's eyes. Many people view pain as a part of life. Some patients experience it for hours or days before seeking healthcare assistance. They often expect and even accept a certain amount of pain while being hospitalized. It is important to learn a patient's own values and beliefs about the management of pain and recognize that patient expectations will influence your ability to achieve outcomes in its management. QSEN, 2014. Asking a patient about his or her tolerable pain level is a first step in helping a patient regain control. Assessing previous pain experiences and effective home interventions provides a foundation on which you can build. Patients expect nurses to accept their reports of pain and be prompt in meeting their pain needs. When assessing pain, be sensitive to the level of discomfort and determine which level will allow your patient to function. For example, when caring for a patient with pain, ask, which level of pain will allow you to walk down the hall? The patient answers that walking is possible when pain is at a level of 2 on a scale of 0 to 10, with 0 being no pain and 10 being worst pain imaginable. You then plan therapies to decrease the patient's pain to that level. Be sure that he or she is a partner in making decisions about the best approaches for managing pain. Another aspect of assessing pain through the patient's eyes is determining his or her health literacy. People who struggle to find a range of words to talk about their pain lack the ability to use language for symptom relief. Psychologists suggest that having a wide vocabulary with which to describe pain symptoms helps equip a person to better manage pain and reduce distress. Many agencies have assessment tools that allow you to get a more accurate measure of a patient's literacy skills. If pain is acute or severe, it is unlikely that a patient is able to provide a detailed description of the entire experience. During an episode of acute pain, streamline your assessment and assess its location, severity, and quality. Collect a more detailed acute pain assessment when the patient is more comfortable, box 44-5. For patients with chronic pain, a thorough pain assessment includes effective 1023 cognitive, behavioral, spiritual, and social dimensions. In the home care setting, family members assess pain. Using the ABCs of pain management is an effective way to manage pain, box 44-6.